Okay, are there any other PS3 problem sets? So I'm going to post the solutions to PS3 this afternoon, possibly as early as like 12:20 if I can do it before going to lunch. So you definitely want to get it in before then, because after that point we will not be accepting any late problem sets for certain. In terms of the grading, so the grader believes she can get these done today or tomorrow, and I'll get them back to you on Friday if that happens. The PS2s, the graded PS2s are sort of making their way around the room right now, so eventually they should make it over to the other side there. If for some reason they miss you, feel free to come up after class and look through them to get yours. I also have graded problem sets 1 from last time as well. Yes, this one is in fact yours. So I'll pass these around to, if you already have yours, if you're looking for it. If not, feel free to grab it. And so I posted the midterms from 2012 and 2011 on the B-Courses website. So not only are the midterms there, but there's also solutions for both of those midterms. So that should give you a much better sense both of the types of questions that are going to be asked, as well as potentially the material that we're going to cover, and then of course what I'm actually looking for in terms of solutions. They're both, I don't know, they're a little bit long for like basically a 55-minute midterm. So I'll probably try to make it slightly shorter this year. I'm going to change the grading slightly as well, which is that for the, I guess pretty much all the problems. So it's going to be more sort of like maybe an SAT format. I forget, the SAT one where you get like a quarter point or something for leaving it blank, and 0 if you put in the wrong one, and like 1 if you put in the right one, so that if you can sort of eliminate some possibilities, then you're better off guessing, and if not, then not. I don't know. It used to be like that. So, excuse me, you get some subtraction. Sure. Yeah. Okay. So this is going to be a little bit similar, just in the sense that I'll probably, for most of the problems, it'll be like you get like, I don't know, maybe 1 point or something if it's blank, and then 0 points if you write down something that is completely wrong and or irrelevant to the problem, and then obviously full credit if you if you put down the right answer. Basically, what I want to discourage is sometimes people don't have any idea, and then they just start writing irrelevant stuff, and it's not helpful for you because it uses up time that you could be using on other problems. It's not helpful for me, the grader, because we have to read stuff that is completely irrelevant, and so there's just no benefit for any party involved if you start writing down random stuff. Just I don't think it's going to be right, because inevitably 99 times out of 100 it's not. Okay. So in terms of what I want to talk about today, we're going to sort of talk about the effects of air pollution on adult health, and maybe depending on sort of if this takes up the entire lecture, then that's fine. If it doesn't, then maybe I'll describe a little bit of my own research that's currently ongoing on this problem as well. So I guess the other sort of minor follow-up item is, so last time we were talking about the case in Dallas of the healthcare worker, the nurse who got exposed to Ebola, and then since then sort of 2 things occurred. One is that a second person, also in the same hospital, has now tested positive, which suggests that the infection control procedures they were using were not adequate, which actually, sadly, if you kind of are familiar with what goes on in U.S. hospitals, is not a big surprise. So that suggests kind of that the risks were higher than probably would have been anticipated by those workers. So if we're sort of redoing the BSL calculation, you'd probably want to the potential BSL calculation, you'd probably want to put in maybe a higher risk than you had used before. On the other hand, there were also at the same time, basically, there were sort of reports by a bunch of anonymous nurses in the hospital, so basically like nurses speaking off record to I don't think it's a union, but basically like a nurse organization that represents nurses, that said that essentially the hospital was like not prepared to deal with this, and it took them days to sort of get the correct procedures in place and so forth. And so they were all off the record because supposedly they had been threatened to be fired if they identified themselves and basically were like acting as whistleblowers. So I think that also suggests that, so if you were rethinking now the calculation of basically marginal willingness to pay or marginal willingness to accept over divided by the potential risk involved. On the one hand, you probably want to start using a larger risk than we had talked about last time. On the other hand, I think that the monetary impact of refusing to treat the patient, of basically saying like you're not going to do your job, is probably also towards the higher end of what we were talking about before. Given that they're theoretically at least threatened to fire the whistleblowers, it seems not unlikely that they might have like fired you if you had refused to sort of go along with whatever they were doing. So overall, maybe the BSL calculation isn't changed or hasn't changed that much, but both the numerator and the denominator in my mind probably gotten bigger than they were before. Okay, so in terms of thinking about the effects of air pollution on adult health, as I mentioned at the very end of the last lecture, the evidence on infant health I think is much stronger. In part, this is because, or the reason that there's been a lot of attention paid to this question is because everybody cares about saving infants and babies. But there's also this fundamental statistical reason that if you think about all of these infant health papers we've talked about, they're all using relatively short-run changes in air pollution. So like sort of spikes in air pollution that occur over like a period of days or weeks or months or maybe 1 year. And you could think then that if an infant is exposed to elevated air pollution levels for even a few months, basically their lifetime exposure to air pollution has gone up significantly. Whereas if you think about exposing an adult to elevated levels of air pollution for a few months, their overall lifetime exposure hasn't really changed all that much. So if you're trying to measure the effects of long-term exposure to pollution on adult health, then you're not going to be able to use the types of research designs or the types of data that we've been using or that you've seen been used with the infant studies. So the bottom line is that it's very difficult to find what we think of as being like quasi-random variation in long-term exposure to air pollution. So certainly there are higher pollution areas and lower pollution areas, and there are long-term differences then in exposure to air pollution depending on whether you live in a region that has high pollution or low pollution. But people sort across regions. So certainly like if you were to say let's compare air pollution levels in China over the last 15 years, air pollution levels in California over the last 15 years, certainly in the Chinese cities air pollution levels are way higher. You might think the mortality would be way higher, and in fact, I'm sure the mortality rate is higher, but of course the population in China is also on average much poorer than the population in the US. There's a tremendous number of cultural differences, economic differences, family structure differences, you name it, it's probably different. And so you can't make any sort of inference that, you can't make any reasonable inference that the higher mortality rate in China relative to the US is all due to differences in air pollution as opposed to differences in all these other factors. Even if you were thinking about randomly assigning air pollution to different areas, so in general, like you couldn't really imagine doing that, but even in the case where you could think about, say, running an experiment where you were going to expose San Francisco to much higher pollution levels over the next 30 years and not expose some control city, say Los Angeles, to higher pollution levels over the next 30 years, even with that experiment, it would still be really difficult to identify the effect of air pollution exposure on mortality because people can sort across areas, right? Like you can't force people to stay in a given city and not move to, say, a cleaner city. So even in that scenario, you would still end up having difficulty measuring the causal effect of air pollution exposure. So this also is sort of a classic issue in sort sort of thinking about what we call, or what you often hear called environmental justice. So this is the idea that essentially if you look in poor areas, you tend to see like dirtier plants located in the poor areas. To a first approximation, it's like the oil refineries are in Richmond, which is relatively poor city. They're not in like Piedmont or Orinda or Palo Alto, which are all relatively rich cities, right? But even there, it's not clear. So that certainly as a fact, that's true. I mean, you have to be crazy to deny it. But in terms of figuring out the causality, it's not clear. It probably runs both ways, right? So just in the sense that if you think about where the polluters are going to locate, they're probably more likely to locate in poor areas because those areas will be cheaper to build in, and there's probably going to be sort of less organized resistance to putting a polluting plant in those areas. So it is true that the polluters are probably sort of sort to be closer to the poor household, but it's also true that after they've located there, they're going to lower property values, and so people who can afford to not live near a polluting plant, of course, are in general going to move away, and the people who remain are going to tend to be poor. So the causality really runs both ways when we start. When we realize that people do have a choice of where they want to locate, and housing prices are going to be higher in areas that have good environmental amenities. So the bottom line is that it's really quite difficult to generate convincing estimates of the effects of long-term exposure to air pollution on adult health. That being said, so the good news is if you just want to sort of focus more on like the effects of short-term fluctuations in air pollution, what effect that has on adult health, that is easier to estimate, and there are studies that produce pretty compelling evidence of adverse effects. So one of these studies, which is sort of actually pretty old by the standards of this literature, came relatively early. But I think it still holds up quite well, is this paper by Ransom and Pope back in 1995. And what they did is they essentially examined the impact of steel mill operations in this particular county in Utah on hospitalizations and deaths. So at that time, or not at the time of the paper, but even at the time when their data were being collected, it was the case that there was basically a single steel mill in this valley in Utah, which is called Utah Valley, somewhat originally. And it generated like 50 to 70% of all of the particulate pollution in that valley. So there's a population of around 200,000 people who are exposed to this pollution, and this single mill is basically the main source of particulate pollution. To make the study credible, they need, of course, a control county that presumably is not affected by the emitter here, which is the steel mill. And so it turns out that there was a nearby valley that, just based on sort of how the air circulates in the region, was not really affected by the operation of the steel mill. It's called Cache Valley. It's significantly smaller, only a population of 70,000, but on sort of most demographic characteristics of looking at like age and household structure and race and so forth, they look pretty similar. So arguably, or Cache Valley is like plausibly a decent control group for Utah Valley. And then, so you need not only a control group, but you need it to be the case that there's some shock that occurs in the treated county that doesn't occur in the control county. That's part of what makes it a control, right? And so what happens here, the time-varying shock, is that from August 1986 through August 1987, so basically for a full year, the steel mill shut down due to a labor dispute. So you can see that what's going to happen here is that Utah Valley is going to start out with presumably like an elevated level of particulate pollution relative to Cache Valley. Then there's going to be the strike that shuts down the mill, which brings the pollution level down to be presumably maybe comparable to Cache Valley. And then eventually it's going to start up again, and the pollution level will go back up. But we can sort of look at whether or not there's a change in health outcomes, in particular like hospitalizations, that coincides with this pattern. So essentially, what we would expect if air pollution has a negative impact on health is that hospitalizations should fall in Utah Valley when the steel mill shuts down, relative to whatever trend we observe in Cache Valley. So this is going to be, again, like a dips and dips type research design that compares changes in hospitalizations in the treated valley, which is Utah, to changes in hospitalizations in the control valley, which is Cache. So they focus on sort of a subset of hospitalizations that they think are going to be most affected here. So things that are in particular like respiratory in nature, you would think would be the things that air pollution would be having the biggest impact on. And so they look at bronchitis and asthma hospitalizations. So those end up falling by 20% in Utah Valley when the steel mill shuts down, which would be consistent with with the mill having an impact on these outcomes. But you might think, well, maybe they're falling just overall in the state for some other reason, right? So you want to look at what's happening in Cache Valley. When they look at Cache Valley, they're actually rising there. So when the mill shuts down, they rise by 8%. So if you did the dips and dips, then it would turn out to be about a 28% effect, right? So you have a negative 20% effect in the treated valley, and then there's actually an increase of 8% going on in the control valley. So if anything, you should have expected the asthma hospitalizations to rise in the treated valley, when in fact they're falling by a pretty substantial amount. So when you take the minus 20%, that's subtract off of 8%, you get around 28%. Furthermore, so this is for, they're looking at both adults and at children. So among preschool age children, you actually see an even bigger effect here. So hospitalizations fall by basically like 50% in the treated valley, but only by 8% in the control valley. So there is pretty strong evidence that hospitalizations are being affected by the mill shutdown, which is to say that they're falling when the mill shuts down. For deaths, there's not sort of really so much evidence. Sorry, a mixture. Okay. So for deaths, the patterns are kind of suggestive that there might be an effect of air pollution on mortality, but they're not. They're actually not statistically significant. So deaths do decrease in the treated valley. They do decrease in the valley where the steel mill shutting down. They rise in the control valley. So if you do the difference, you get sort of like about a 10%, 10 or 11% decrease in deaths in the treated valley relative to the control valley. But the difference isn't quite significant, so you can't really interpret it as being strong evidence of any effect on mortality. They also use sort of fancier regression models that control for like seasonal effects and time trends and so forth. The bottom line is that the basic conclusions you see above there are not really changed as they add in more controls that they have available to them. So overall, there's a pretty clear impact on hospitalizations for respiratory disease, but it's not so clear whether or not there's an impact on mortality. Basically, the way that you would want to view their findings of mortality is they don't really have enough precision to make a decision or to make a conclusion one way or the other. They don't find a significant effect, but they also couldn't rule out like a reasonably large effect. There's just not enough statistical precision there. So another paper in this literature that I think is quite nice is a paper by Enrico Moretti, who's here in the econ department, and Matt Nadell, who's at Columbia. And they do sort of a more recent twist on the Ransom and Pope research design. So what they do is they use daily variation in ozone levels in Los Angeles that's generated by ships' arrivals and departures in the Los Angeles and Long Beach ports. So Long Beach, I think, is probably the busiest port in the U.S. Certainly, it's like one of the two busiest ports in the U.S. and certainly the busiest port on the West Coast. So they do get a lot of shipping traffic there. And it turns out that it doesn't just like arrive uniformly, day by day. So the underlying idea here is that boat arrivals and departures should be uncorrelated with any other factors that determine like the respiratory health of the Los Angeles area population, certainly after you control for season and per day of week. But so they should be sort of uncorrelated with things that might cause hospitalizations, but they should generate variation in air pollution. So the idea is essentially that if we just look at variation or we just look at changes in air pollution that are being caused by whether or not there's a lot of boats arriving on a given day versus whether or not there aren't a lot of boats arriving on a given day, that those changes in air pollution should be sort of as good as randomly assigned from our perspective. If you wanted to sort of like, so I guess you can't really quite set up as a difference in differences design because there's not really a control group. And if they wanted to, I guess they could sort of use some control group that's further away. But this is really just what you want to think of it is basically these boats are sort of random shocks to the air pollution levels in the Los Angeles area that happen sort of day by day. So you're sort of randomly assigning lots of boats to arrive on one day and few boats to arrive on the other day. And as you do that random assignment, you're going to either be generating lots of air pollution or lower amounts of air pollution. Now, of course, we're not literally randomly assigning the arrivals of the boats, but they essentially argue that you could view them as being as good as randomly assigned because it's not at all clear why the number of boat arrivals on a given day would be correlated with anything else that determines respiratory illnesses other than air pollution itself. Now, what I just said is not quite true until, as it says here, until you sort of control for things like the season and the day of the week, right? So certainly you would think probably there's more boats maybe arriving on weekdays than weekends, right? So if you didn't control for the day of the week that it was, what you might find is that there's sort of more air pollution when there's more boats, but it also tends to be a weekday when there's more boats, and maybe for other reasons, like people just have more respiratory illnesses on weekdays because they're at work instead of relaxing at home, or the kids are at school and like running around all day instead of inside or something like that. So you definitely want to control for the day of the week, and then you also should probably control for like potential seasonal effects, right? So certainly you could think that respiratory illnesses could have a seasonal component to them, both because of allergies and just sort of air pollution levels in general and so forth. And there could also be seasonality in boat arrivals and departures. I don't know exactly sort of what the peak seasons would be, but you can imagine there might be more boats arriving on average during the summer or less boats arriving on average during the summer relative to the winter. Fortunately, those things are very easy to control for, right? You always observe the day of the week, and you can also put in indicators for like maybe the month of the year or something to capture any seasonal trends. So these are those factors they can easily control for, and the argument is after controlling for those factors, the boat arrivals and departures should be pretty much as good as randomly assigned. So the idea then is going to just be to compare hospitalizations for respiratory illnesses on days that have high levels of boat traffic to the number of hospitalizations for these illnesses on days that have low levels of boat traffic. Another sort of added benefit of this is that it eliminates issues with something that we call avoidance behavior. So there's been work done sort of prior to this study, in particular by Matt Nadal and one of the others on the study, which showed that at least in the Los Angeles area, people do in fact respond to the like air pollution in the spare the air type days, not so much in terms of, so not necessarily in terms of like avoiding activities that would create air pollution, which is the goal of declaring spare the air day, but rather to the health warnings that are associated with them. So, so if there's like if it's forecast to be a high pollution day, first of all, they'll sort of ask people to try to take transit instead of driving. Don't like go out and mow your lawn with a gas lawnmower, do various things to potentially reduce pollution levels. But then also they'll tell people who are at risk of respiratory diseases, or they'll give information that people at risk of respiratory diseases should respond to that. They might want to like limit the amount of time they spend outdoors or not engage in like strenuous physical exercise or anything that could like trigger an asthma attack or something like that. And so Matt showed that in fact it is the case that at least in Los Angeles, people do respond to these declarations. So he essentially showed that when you're sort of right on the margin, like they have an index, an air quality index, where they basically make a forecast of what the air quality is going to be, and sometimes that forecast is good and sometimes it's bad. And so essentially he sort of uses a random variation in the quality of the forecast to show that basically like when they are sort of right on the margin of declaring the spare the air day or declaring that the air quality is going to be bad versus good, if they end up declaring that it's going to be bad, you do see reductions in I think patronage of like sort of outdoor places that people who have illnesses should be avoiding. So enables to like Griffin Observatory, various like sort of public spaces in Los Angeles that take where they actually sort of collect data on how many people are being admitted into it. So you think of like I don't think it's like the zoo, but you can think of some various places like that, like museums and stuff. Basically, it is the case that when they're forecasting the bad air pollution day, they people do end up avoiding going outdoors. And what that's going to do is actually, so to the extent that people are engaging in what we call this avoidance behavior, basically taking precautions to avoid making themselves sick if it's going to be a higher pollution day, what that's going to do is potentially sort of like attenuate the types of effects that you might estimate between pollution and health, right? Because if people are taking protective measures, then presumably protective measures will be at least somewhat effective, and you're going to see sort of less illness than you would if they weren't taking these protective measures. So the argument here is that there can't be, so basically like given the type of variation that they're using here, this variation in boat traffic, it's not going to be associated with any sort of avoidance behavior because boat traffic isn't actually factored into the air quality forecast, right? So the way that you want to view this, like most of the changes in air pollution that occur in Los Angeles are being forecast by the air quality district, and therefore, if you are concerned that you might get sick, you can look at these forecasts and curtail your activities on days where there's forecast to be bad pollution levels. But when they're just looking at pollution that's basically being generated by variation in boat traffic, this isn't something that the air quality district takes into account in their forecast, or at least historically did not. And so it's not something where people can actually engage in avoidance behavior to try to limit their activity. So like the way you want to think of this is that if a whole bunch of boats arrive, it increases pollution levels, but nobody realizes that all these boats are arriving other than maybe some people who work in the port. So there's not going to be any precautions that are being taken to try to reduce exposure to air pollution. So the bottom line is potentially you think that the effects they're going to estimate are going to be larger than the effects of some of the other studies, just because people don't have this ability to engage in the avoidance behavior in this case. So what they find is that ozone does cause significant changes in hospitalizations for respiratory illnesses. So they sort of normalize things by looking at how many kilotons of boat traffic are coming in.